Welcome back. Short lecture today on research methods in abnormal psychology. You may have noticed from the reading that 90% of the concepts are review from your intro psych. In partial acknowledgement of this, I gave you the shortest abnormal psych research methods chapter that I could find. We'll start with some general commentary on concepts. Abnormal psychology, like psychology in general, is full of concepts that can both aid and hamper or hinder our understanding. Sometimes they're helpful, sometimes they're not. This is from Chapter 4 of the Flett Abnormal Psychology textbook. That's the textbook from which I took your Chapter 1 reading. Up here we have all of the way that situations are related to behavior. So taking an exam can make you report feeling tense. It can lead to physiological changes associated with tension and sympathetic activity. And taking that examination can also make your hand shake. But of course, any of these behaviors could also be elicited by something else, like expecting to receive an electric shock or having a fight with your significant other. But look at all of these arrows and relations. Isn't this far too complicated? Too many things are happening here. What's some sort of singular factor that relates taking an exam, expecting a shock, and fighting with your significant other to the behaviors of reporting tension, increased heart rate, and a shaking hand? Well, we could replace all of this complexity and link all these things together with the concept of anxiety. Look how much simpler and how much more manageable our world got thanks to the concept of anxiety. This is firstly and obviously a great way to understand how all these three things are connected, on the left to the three things on the right. But of course, in your messy 3 pounds of meat that thinks, in your brain, when you lump like this, when you get rid of all the individual lines for a concept like anxiety, you run the risk of blurring things that aren't necessarily a good thing to blur. So let's say I traded my more detailed upper diagram with all those lines and arrows for the nice, tight, compact understanding in the lower diagram facilitated by the concept of anxiety. But then let's say I was reading a heavy book and I had my neck in a funny way, I had a funny posture when I was reading my book, such that I ended up with a tension headache. A headache due to tensed muscles. Well, if I incorrectly tie that back to anxiety, as opposed to saying, oh, I seem tense, do I have an upcoming test, electric shock, or fight with my significant other? This might lead me to look for other signs, like physiological changes, in an effort to conclude that I must be feeling anxious because I'm experiencing a form of tension, which opens the door to self-fulfilling prophecies and nocebo effects simply through spreading activation in our brain. The point being that a general use concept is subject to what I like to call creep, or irrational or inaccurate spreading, a conscious or unconscious reasoning by analogy, due to a lack of rigor, combined with just the fact that our brains are wired up associatively. The folk wisdom here is when you have a hammer, everything looks like a nail. When you have the concept of anxiety, everything looks like a potential threat or discomforting problem. We'll get more into why this is especially a problem for anxiety in Lecture 5. At this point, I can put the question to you. Are there any places where you notice the concepts you have, like anxiety, getting in your way, or getting in the way of other individuals? The low-hanging fruit here would be negative self-talk. So is there anything you say to yourself, or you hear other people say to themselves, that might start with, I can't because. I can't study because the textbook's boring and I'm kind of ADD. I can't talk to her because she says a lot and it really bugs me and I'm really picky about things like that. I can't plan and organize my life because the future freaks me out. I'm depressed, nervous, overwhelmed. This is a case where the concept or self-understanding might be creeping a little too much and preventing you from drawing individual lines that may be helpful for a specific understanding and preventing a kind of blurred and sweeping misunderstanding or emotional snowballing or conceptual overload that might look like self-understanding on one level, but might not be doing the job that self-understanding should, which is helping you act and manage yourself with discernment and perspective. What are you thinking that's not working? What concepts are getting in your way? Probably easier to identify this in other people. It's probably easier to observe other people suffering from concept creep than to observe it or admit to it in your own mind or experience, but consider it for self-reflection. Our first concept Correlation. An example of an observed correlation from abnormal psychology that has not aged well, Bettelheim's refrigerator mother hypothesis. The idea here was that autism is caused by cold mothers. Why are there children who don't connect emotionally, resonate, and social reference the way that other children do? Well, said Bruno Bettelheim, these children are victims of mothers who did not connect emotionally with them, and so they don't look for emotional connection in others as a result. Now, obviously, this is not the actual reason why individuals with autism are the way they are, or experience the world the way they do. But I would like to point out that Bruno Bettelheim was not just pulling this out of thin air, he was making an observation based on correlation. By most accounts, autism is the most genetically linked or genetically determined psychological disorder, much more so than even schizophrenia. This means that many of the children with autism that he was seeing would also likely have had at least one parent on or near the autism spectrum. As someone with 7.5 years of experience testing kids, it is frequently the case that children will resemble their parents in terms of their ways of experiencing the world. So presumably, Bettelheim made a few observations. There were a few cases where the child was on the spectrum and the mother was approaching the spectrum, and he firstly overgeneralized and secondly made the wrong causal inference. This is what we're wired up to do, to connect things together and then look for instances that support the connection we made. Epidemiology is where we try to find good ways of figuring out or determining cause from correlations. A popular one being the apparent increase in autism, which most psychologists and psychiatrists will tell you is due to changing diagnostic criteria, and lots of people in social work and policy management will tell you is due to an increase in available accommodations and funds that are made available to people based on diagnosis. Now, these factors could be the cause of more individuals being diagnosed with autism, but if you've read the internet, there's a million other theories as to why the number of individuals with diagnosed autism seems to be increasing. Many people are turning correlations into causes, and it's epidemiology that tends to have the best way of teasing apart plausible from implausible explanations. Let's say I'm an epidemiologist, and, like most people who don't think science is a conspiracy against humanity, I don't think that autism is caused by vaccines. But, being a scientist, I need, as a professional, to look in the area of the world that would be most capable of proving me wrong. If the measles, mumps, and rubella vaccine had the slightest chance of increasing autism, then the place where it would be most likely to do so would be in those most at risk of getting autism to begin with. I mentioned the strong genetic risk factor, so one group of individuals who would be quite at risk for developing autism would be kids with siblings with autism. So, as epidemiologists, let's go into the records and let's find 4 different groups of individuals. You have the individuals who have older siblings with autism. You have individuals who have older siblings without autism. And these younger siblings could themselves have either received or not received MMR vaccination. So your 4 groups are kids who were vaccinated who had an older sibling without autism, kids who were vaccinated who had an older sibling with autism, kids who were not vaccinated who had an older sibling without autism, and kids who were not vaccinated who had an older sibling with autism. And you can compare across these groups rates of autism in these younger siblings. Specifically, is there more autism in the group of younger siblings who got the MMR vaccine? If it increases your risk even a little bit, this most at-risk population would be the population in which that risk would be noticeable, would be manifest. So the epidemiologists compared these groups and noticed that, quote, receipt of the MMR vaccine was not associated with increased risk of autism spectrum disorder, regardless of whether older siblings had autism spectrum disorder. These findings indicate no harmful association between MMR vaccine receipt and autism spectrum disorder, even among children already at higher risk for autism spectrum disorder. And this is how epidemiology works. You can't run a randomized controlled trial, but you can go back in the records and you can say, well, if an increased risk could be found anywhere, it would be found here. Let's see if we find one. And in this case, they did not find an increased risk of autism due to vaccination with the MMR vaccine. Case studies are a great way to improve your understanding of abnormal psychology. Norman Endler was the chair of the psychology department at York University, and he experienced bipolar depressive disorder. This is the cover of his autobiographical account, which has been out of print for quite some time. But a summary of the progression of his disorder is that in the 1976 academic year, Endler became obsessed with playing tennis 3 to 5 times per week. He describes himself as always being on the go at this point, in overdrive, flitting all over the place. That's the quote. He would ask his secretary a question and then leave the room before she could answer. By his own description, he would never sit still. He was vacationing, organizing symposiums, working, so he was doing too much. He notes about a conference that he was organizing in February of 1977, quote, "As an index of my hypomanic activity, I had arranged to introduce most of the invited speakers myself." That's a lot of work. He was at the height of his success. He'd brought his body weight down to what it had been when he was a teenager, and he was full of energy. Then, in April of 1977, he discovered that his Canada Council research grant was not being renewed, and his tennis partner, who he admits he had actually been sexually infatuated with, informed him that she wanted to wind down their tennis relationship, and that same month, his sex drive failed with his wife. By the middle of April, he was experiencing difficulty sleeping, loss of appetite, he was overwhelmed by his job, and his sex drive was, in his own words, gone. In May, hospital secretaries, psychiatric nurses, and his wife all told him something was wrong. One of his jobs was he worked at Clark Institute of Psychiatry. He says that he felt tense, queasy, jittery, he couldn't sit still, he had difficulty eating, sleeping, reading, and concentrating. And again, in his own words, his sex life was zilch. In June, he sought help, and he was tired, irritable, anxious, sad, unsure. In short, he writes, depressed. And he could, quote, no longer deal with day-to-day tasks. His family doctor prescribed Valium, which is a tranquilizer, and amitriptyline, which is an antidepressant, and a specialist, Dr. Prasad, later increased his antidepressant dose and diagnosed him with unipolar depression, i.e. just depression. By mid-June, that higher antidepressant dose was preventing Endler from urinating. So they switched him to a tranquilizer, and then he had several days of hypomanic symptoms. So a few days later, he was put on Valium and Tofranil. But the urination problem was so bad that he was, in his own words, in hysteria over his inability to urinate. So they put him on a stronger tranquilizer. And by this time, it's almost been 2 months, so he should have expected the depression to start waning or the medication to kick in. So they said, I guess it's not working. So they switched him to an MAO inhibitor. But he had 2 episodes of hypertensive reaction to this MAOI, so they took him off of it and placed him on a tricyclic. At this point, his symptoms were actually getting worse, and he said he started to experience paranoia and a secondary depression, i.e. depression because the depression wasn't lifting. At this point, his specialist, Dr. Prasad, gave him an option. He said, you can undergo electroconvulsive therapy or be hospitalized in a psychiatric institution. So it's September in 1977, and Endler has his first electroconvulsive therapy treatment. He goes through 7 treatments, and later on in the month of September, he gets his sex drive back, he gets back up playing tennis, and he even gets taken off of the Valium and other medications. But by the time he gets to November, he's experiencing hypomania. His wife warns him about this, but he doesn't listen because when you're hypomanic, you feel great. You feel like the best version of you. But what comes after the hypomania is depression. So by the time we get around to mid-April of 1978, his depression is back. He's quiet, no sex drive, no appetite, can't sleep, dry throat, jittery, anxious, nervous, tense. He gets back on a tricyclic and Valium, and he can't concentrate, so he doesn't waste time. He goes back for more electroconvulsive therapy treatments. This round of 7 treatments doesn't quite cut it. They increase his medication, but he's still anxious. They figure he's developed a tolerance to Valium, so they switch him to Ativan. By now it's mid-July, and his specialist, Dr. Prasad, says, I think you may be improving, but you're probably going to hop into hypomania, so I'm going to put you on lithium to prevent that hypomanic episode because that's what cycles down into depression. So in July of 1978, as Endler describes it, his second depression, this is the quote, his second depression lifted imperceptibly with a whimper. Because he was on the lithium, he didn't move into a hypomanic state. They kept him on medication, Elavil, until September of 1978, after which he only used a maintenance dose of lithium. So all of that from the hypomania in 1976 to his recovery from bipolar depressive disorder in September of 1978 describes his biomedical treatment. That, in and of itself, is quite interesting, but along the way, in the roughly 150 pages of his autobiography, we get to see how his colleagues responded to him. We get to see a good case of how stigma works among individuals who should be very much aware of the proper way to interact with an individual with bipolar depression. So firstly, his close colleagues, his confidants, told him, don't let anybody know that you have depression. His family doctor referred him to someone 30 miles away, and that specialist said that if Endler had to be hospitalized, institutionalized, he would send him to Guelph, which was 50 miles from where he lived. There are, of course, far more good options closer to Toronto, and the justification was that he was too well known at the Toronto psychiatric institutions. One of the psychiatrists he worked with told him he should use a pseudonym so that nobody finds out that he was treated for depression. He notes that a lot of his fellow professors at York University told him not to write his autobiography because admitting he had had depression would destroy his career. When the Department of Psychology sent out a memo explaining Endler's situation, they said he was suffering from exhaustion and not depression. And when his colleagues in the psychology department found out that he was undergoing electroconvulsive therapy, the typical response was to call it barbaric and try to talk him out of it. One of his colleagues asked him why he was, quote, willing to get half your brains burned out. And another psychology professor said, why would you, quote, let them do this to you? As if electroconvulsive therapy was somehow designed or intended to harm him. So through reading about Norman Endler's experience, we don't just learn about the scattershot approach of medication, seeing what works, what doesn't, which side effects can be tolerated and which can't. We also learn about the context and how this contributes to not necessarily what's wrong, but at least what's different when one is experiencing mental illness. There's all kinds of judgment, people making decisions for you, trying to help, but they don't necessarily know how, people giving advice, talking in hushed tones, walking on eggshells, prophesying your doom, like telling you you're going to get half of your brains burned out. It's these types of details, this scene setting, that really make case studies a great source for understanding, contextualizing, perspective taking, and picking up a case study is a great way to get conceptually unstuck, to reinfuse the dynamic humanity of an individual in a circumstance rather than just a condition and its treatment modalities. Case studies humanize their subjects and let us into their perspectives in part by showing us the range of their experience. So we can identify with the individual in the case study when they are feeling the way we are. And then maybe we can extend that understanding a little bit when their mood starts to get more extreme, when their symptoms start to get a little bit worse. We can extend the bonding or coupling or identification we did in part 1 of the case study to this more extreme experience that they're having later on. Interestingly, in the case of Norman Endler, it took quite a while for Dr. Bersad to come around to diagnosing him with bipolar because even though Endler's mood was hypomanic in 1976, Endler hadn't seen a problem with it until he recontextualized it in light of his later hypomanic states. You could also say that an autobiography gives us a chance to spend time with the subject and experience getting a baseline for the person's behavior. Spending a few months with Dave is going to give us a more interesting or more varied story than spending a few months with Jane, at least in terms of their scores, journeys, or symptomatologies along whatever trait is being displayed here. So case studies and the individual variation that they give us time to experience and observe in the individual help us understand not just the symptoms or the presentation, but also the fact that the symptoms aren't always there. And when they are there, how different those symptoms or that symptomatic state is from the individual client's normal is going to depend on the client. Depression is a larger departure from normal for some people than for others. But we have, of course, all experienced variability on traits, on emotions, on competencies. We have all experienced variation within ourselves. An exercise you can do to help yourself understand abnormal psychology at least a little better is to try to recall a time when the magnitude of your own emotion or response frightened you. Has there ever been a time when you were so scared or so angry or so unmotivated that it frightened you? Whether the fright came from realizing that you were capable of such variation or the inference that whatever you were experiencing in the world was something new and scary that you had to orient to. Whatever the reason for the fright, can you recall the magnitude of the emotion or the response that you had that led to that evaluation of your response as, ooh, this is a frightening response that I'm having? My personal example is that there have been a couple times in my life where in the heat of the moment, I considered engaging physically with someone, fighting a stranger for reasons other than saving my life. These were fleeting feelings, but it frightened me to find out that I was capable of that impulse. Even though I didn't act on it, I discovered how close I could come to choosing that, because I've been engaged in physical alterations defensively. What I'm referring to was the urge to start a fight. The power of that anger or aggressive urge frightened me. Another example that perhaps more of you will be able to relate to is the strange, lingering feeling of fear or threat after you've seen a scary movie. I don't know about you, but I find it a little bit frightening in a meta sense that simply watching The Exorcist or The Exorcism of Emily Rose can make me more fearful of the dark corners of my own house. I understand the adaptive psychology of it, and how it's tricking an evolutionarily very useful part of my brain, but it's a bit frightening to think that 90 minutes of fiction is all it takes to make the most primitive parts of my brain fear my own bedroom. This type of fear, incidentally, which you may remember from being a kid, having watched a horror movie as a kid, and then been extra wary of the basement or something like that. This type of fear has been increasingly recognized as a feature of the experiences of many individuals with psychosis. It shouldn't be too much of a stretch of your imagination to see that experiencing a hallucination could be a lot like the nearly hallucinatory state of thinking your own staircase might suddenly have a creepy possessed child crawl down it. So I use this question in class to help students understand that they have experienced abnormal psychology, at least psychology that's abnormal for them. The longer you live, the more likely you are to experience the rare fringes of extreme emotion within your own particular bell curve, and the more likely you are to have moments that just completely shatter the normal range of that bell curve, and maybe what you experience is abnormal for most humans. And when that's the case, that's when you're likely to have trouble adapting to the environment, or staying adapted to the environment, because you're experiencing a way of being that the world just isn't made for, or ready for, or optimized for. So I suggest taking some time to come up with an example or two for this question. Back in the day, case studies were a narrative affair, mostly put together by, psychodynamic therapists and doctors who, by virtue of their authority, controlled the story of your therapy, your progress, your symptoms, and this hasn't necessarily changed too much. But in the days of the DSM-1 and DSM-2, Aaron Beck came up with some tools that could be used as an alternative or an adjunct to what the clinician therapist doctor was saying. Most famous is likely his Beck Depression Inventory, and here's what it gave us. If you spend 6 months in therapy, I might have your Beck Depression Inventory score at intake and after every month. So I have 7 depression inventory scores for you, and I can see at the end of those 6 months whether your score has gone down, whether this was a gradual slope down, and how much your depression score fluctuated in that time. This means your therapist can't just say that you got much better. There's a score, a measure that your therapist's assessment should align with. Beck also gave us an anxiety inventory, a hopelessness scale, hopelessness being one of the few decent predictors related to suicidality, which he also has another scale that's pertinent to. This ability to score your symptoms does more than just dethrone the doctor or clinician as judger or narrator. It also gives us some options for single-subject experiments, the most simple of which would just be trying something and then seeing if it works. So at time A, I might get your baseline. When you first come in, I take your depression score, and then maybe I give you talk therapy and see whether at the end of 5 or 6 sessions we've done any good. So here I'm just looking for a difference from time A to time B. Did what I do in the intervening time between A and B make a difference? But of course, you don't have a control group here, so it could have just been time, or it could have been some other variable, could have been normal fluctuation. Any of these other things could have caused the difference that we observe from time A to time B. So you could up the power a little bit and do an ABA test, or what's called a withdrawal test. So I have your score at baseline, and then I have your score with the intervention, and then maybe I take the intervention away. For ease of exposition, let's just say it was a tranquilizer. We had you at baseline anxiety score, and then your anxiety score and the tranquilizer, and then, in order to see whether the reduction in anxiety that resulted, we think, from your being on the tranquilizer, goes away when we remove the tranquilizer. If the decrease in anxiety between the initial A and B is due to the tranquilizer, then that anxiety should come back if we remove the tranquilizer. And if the anxiety does go back up once we remove the tranquilizer, well, then this withdrawal study will likely turn into a reversal study, because we're probably going to give you the tranquilizer again and hopefully see your anxiety go down again once we give you back the tranquilizer. And we can turn up the power a little bit more by using a multiple baseline approach. For this example, let's say our intervention for you to manage your anxiety is a breathing exercise. So when you feel anxious, just remember this specific type of breathing and do it calmly while you go about your business. We could do an A/B test with this, so we can get your baseline of anxiety before you use this, and then an assessment when you are using the strategy. Then we could do a withdrawal version of that. We say, okay, for a time, don't use this breathing technique anymore. Go back to the behavior you were engaging in as usual, because maybe it's not the breathing that's been helping you. Maybe you just changed on your own, and that could turn into a reversal study. But let's say we wouldn't be satisfied with that. We want to be able to rule out general time series types of effects here. So we might teach the client the breathing technique, but say to the client that they should only use the breathing technique at work. So we get a baseline for their anxiety at work, before breathing technique and during breathing technique. But during this time, if they're experiencing anxiety at home or at school, they're not using the breathing technique. So we have the difference between A and B across work, school, and home for that given week. And if it's the breathing that's improving things, then we should only see anxiety improvement at work. And then the next week, we could say, okay, use the breathing technique at home, and we'll look for a difference between A and B at home. And then the next week, it could be at school. We may not have a control group for this client, but we are doing a progressively better job of finding out whether client improvement is indeed tied to our intervention, or whether client change is tied to or caused by whatever it is we're manipulating. For another example of a case study and a chance to review our clinical description terms, let's look at Natalie. This is a case taken from the book Biology of Desire by Lewis, who, along with Gabor Mate, is our current Canadian voice on addictions issues. Natalie was a liberal arts student. She was outgoing and from a small town. She started experimenting with a few different drugs, all of which were fun, but none of which were exactly life-changing. She reported that these drugs would help her push down the anxieties of life and quiet a kind of general hum of fear and anxiety that she had, particularly fear of failure. It wasn't until she tried opioids that she actually experienced a drug-induced vanishing of these anxieties. So when she was high on opioids, this anxiety that she could previously only kind of push down and ignore disappeared and melted away. Despite being successful in life, work, love, school, she still felt that she needed this high. And at first, when she was using, she could go even weeks without using, so there wasn't much reason for her to think that she was getting addicted. But eventually, she started to get withdrawal symptoms, stomach pain and breathing issues if she went those few weeks. So that's withdrawal, and she was also starting to experience tolerance, i.e. needing more of the same substance in order to get the same level of high. And as tends to happen with opioids, things like OxyContin are quite expensive. You can get stuff that's harder for cheaper. So Natalie switched to heroin. So now she was a heroin user. She wasn't injecting yet, but she was a heroin user, and through this she maintained her school grades, her employment, and her romantic relationship. But as tolerance and withdrawal increased, she sought more efficient ways or more effective ways of using. So she went from smoking to snorting, and then she saw a friend of a friend injecting heroin, and she said, "Show me how to do that. I want to know how to do that." And she said that the first time she injected heroin felt like the first time she got high on OxyContin. In other words, once again, everything melted away. So now she's an injection heroin user, and she reports that every day, more and more of reality seems to fall away, such that the only thing that's left is a focus on her next injection. At this point, she reports she can't really go more than a day, maybe two, without shooting up because of the withdrawal. Obtaining the substance became the only thing she could think about. She lost sleep because she was constantly checking her phone rather than sleeping in order to see whether her dealer or her boyfriend could get the substance. And she notes a big existential turn, as well as her view of herself changes from a quiet, bookish, successful student to, in her words, the raunched out chick playing the blues in the bus station, living on the edge. A life of craving and desperation. So she discusses this issue with her housemates, and they agree that they have a drug problem. But this doesn't actually lead to change. The change came when the police were responding to a hit and run that one of their friends committed with her roommate's car. So they were engaged in a hit and run, and then drove back to the house. The police responded to the call. They found the car. They looked in the window. They saw the drug paraphernalia, arrested a lot of them for possession. Natalie ended up with just 1 year of outpatient treatment. But this was group therapy with a group of individuals who were much older and mostly alcoholics. In other words, Natalie didn't identify with them at all. You're supposed to be able to connect and understand and learn from your group members, and Natalie was just not connecting. This is quite the failure on the part of the outpatient treatment because it's supposed to be individualized, and it was clearly not the right place for Natalie. She took back up the heroin habit and faked her urine tests. Her habit ramped back up to injecting heroin every day. She got caught again, but got let off with a warning. She got caught again, and they sent her to a 30-day rehab in a building with other individuals. She again didn't identify with these individuals. After the 30 days there, they followed up with her as an outpatient as well, and things were looking good because she got a job, but she began using again despite being the subject of follow-up with probation officers. At this point, she says that she was taking heroin just to feel okay. It wasn't for the high anymore, it was that when she took heroin, that was the only time she felt okay. But of course, it's the withdrawal symptoms that require her to take heroin in order to feel okay, so she's stuck in a vicious cycle. On one occasion, she slept through an appointment she was supposed to have with her probation officer, so the probation officer came to her place of residence and said, "Are you using drugs?" And she said no, and said, "Okay, well then you probably won't mind if I look in your underwear drawer," and there were drugs there. So this time they threw the book at her. For possession of this heroin, she was sentenced to 9 months of maximum security prison. Do not pass go, do not collect $200. She was taken directly from court to prison. And despite how long and many chaptered this tale has been so far, this is the first time that Natalie's family learns that she had been involved with drugs. So at this point, we can pause and go through our clinical description terms again. What's being described here? Natalie thinks obsessively about injecting heroin and is unable to remain abstinent. It is the present tense, and it appears to be what's wrong, so it kind of looks like the presenting problem. Next, Heroin withdrawal is associated with increasing abdominal discomfort, which could exacerbate Natalie's anxiety over just being okay. So what's being discussed here is what could be expected to happen generally. The reference to Natalie is just a could. It's not an actual prediction that's being made, so this is just a course. This is what we expect, or tend to see, with heroin withdrawal in general. Next, roughly 0.37% of the population are opioid addicted in a given year. So this is the yearly prevalence. Next, with the help of family and forced abstinence, recovery can be accomplished. Likelihood is fair to good. Here's your subjective judgment types of words, fair, good, that indicate we're talking about the prognosis. Next, after experimenting with other drugs, Natalie discovered that OxyContin was the first to completely quiet her general everyday concerns. Note the past tense. This is telling the origin story of Natalie's problem. It is the etiology. Finally, we have seen more cases of opioid abuse so far in the current year than any other year on record. The language here isn't terribly precise, but it's clear enough to know that we're talking about the incidence. So these are aspects of the clinical description, which is an aspect of the clinical assessment, your systematic evaluation, and where you can, measurement of biological, psychological, and social factors. Something we might do at each of these three levels. At the biological level, we could do something called a naloxone challenge test. Essentially, if administration of naloxone sends you into withdrawal, that means you had opioids in your system. We want you to be able to pass the naloxone challenge test before we give you other types of supplemental or replacement opioids. So if we're starting you on methadone treatment or buprenorphine or naltrexone, which if you take it, it should prevent you from experiencing the high of opioids. But in order to get our dosage right, our calibration right for methadone, buprenorphine, or naltrexone treatments, we need to make sure we're starting from the right baseline so that we don't overdose you generally and underdose you in terms of what you need moving forward. There's also, of course, urine tests to see if there's any in your system. On the psychological level, we could do a structured clinical interview for the DSM. It's called a SCID assessment, the point of which is to walk through the diagnostic criteria that we talked about last lecture and see whether Natalie qualifies for a opioid use disorder. And we could also do a SCID assessment for diagnosis of potential anxiety disorders, and this would let us look at diagnosis proper. It would let us look at the severity, mild, moderate, or severe, and might help us look in other places, for example, focus in on her anxiety, in order to see how we might need to individualize her treatment, because we do need to individualize her treatment. There are also various ways that we could assess the social level or social dimension of Natalie's experience. We could ask about or speak to her peers, request that she engage with drug court, see what kind of support she actually needs, and try to determine what change in context she needs that she hasn't been getting yet. The famous example with addictions is the heroin-addicted Vietnam veterans who, when they came back to the U.S., something like 90% of them simply recovered. They went through withdrawal and they worked through it. It was such a change in context from fighting in the jungle to being back home, maybe because they couldn't find heroin, maybe because the motivation to take it had changed. Whatever the reason, the big change in context was apparently enough for most of the Vietnam veterans. And the actual conclusion of Natalie's case was that the change in context worked for her. She had the 9 months of forced sobriety, during which time she made use of the prison library to teach herself meditation as a way of dealing with her anxiety. And when she was released, she went to live with family in a place where she had never used before, and where she had support. And she reports that she only went back to trying pills once and has been sober since, and she now works helping other individuals get through their addictions. Finally, controlled experiments. Compared to what? Now, previously, we were dealing with case studies, individual cases, where we didn't have a control group. You don't have a control group, unfortunately. You only have one existence. You don't get to see what happened to you in other timelines when you made other decisions. But when we're testing for the overall effectiveness of a thing, well, we can have multiple clients or people engaging in one paradigm and multiple clients or patients engaging in another paradigm. And if we make those two groups as similar as possible, hopefully by randomizing individuals to treatment types, then we might be able to make meaningful inferences regarding differences between treatment methods if the two groups have different results. The example here is exposure therapy. Now, cognitive behavioral therapy tends to get a lot of very good press, but there isn't as much justification as you might think for the C aspect, the cognitive aspect. The assumption that cognitive approaches make that we can meaningfully measure and change cognitions is not on as firm a footing as you might think. Exposure therapy is a type of behavioral therapy whereby you behave in a way that you might be anxious or fearful of behaving, such as exposing yourself to heights or challenges, or germs or people or bugs, etc. If in the course of this exposure nothing bad happens, then your nervous system learns this. That's the behavioral approach. The cognitive behavioral approach is to first address catastrophizing and to kind of set the groundwork so that you don't freak yourself out during the exposure therapy process, which could turn a benign encounter into something terrible. But any argument you make for CBT should be predicated upon the fact that CBT is better than just BT. Why do we need all the extra sessions where we unpack my catastrophizing, my black and white thinking? What research results justify this extra work? CBT practitioners can very easily show you papers that say that CBT is better than nothing, CBT is better than a wait list, and CBT is better than placebo. But can they show me that CBT, which is quite expensive, long, and involved, is better than just BT, which in some instances is done in just 1 or 2 sessions, though that's not typical. This is the structure and idea of controlled experiments. You're comparing something to something else, and you're trying to make that comparison as impressive as possible. When we're looking for new effects, we compare a group where the relation of interest might be seen to a similar group where the relation could not be seen. So, in the CBT versus BT example, the effects of the cognitive intervention cannot be seen in the behavioral therapy intervention group. So if the CBT group does worse than the BT group, it might be due to the C, to the cognitive work. If the CBT and the BT group recover from their anxiety disorders to the same degree, then maybe doing the extra C, the extra cognitive work, is a waste of time and money. Going back to the vaccines and autism example, there was a great natural experiment in the Japanese city of Yokohama. Due to trouble with the supply, the MMR vaccination rate in Yokohama from 1988 to 1992 decreased from 70% of children vaccinated for MMR to 45%, 35%, 25%, less than 10%, until in 93, 94, 95, and 96, nobody was getting vaccinated for measles, mumps, and rubella. We have a steady decrease to 0 of kids getting their MMR shots. But what we see in the shading in the background are the incidence rates of autism in Yokohama. Just like they did everywhere else, autism rates went up in Yokohama as vaccination decreased and flatlined. If we were in the habit of interpreting correlation causally, then this, being a negative correlation, would lead us to conclude that the MMR vaccine had been protecting kids from autism, because as vaccination rates went down, autism went up. But of course the point made by the study is actually that vaccination and autism aren't actually related. This is the not so intuitive side of the logic of control groups, because what we have here is essentially the control group. This is the place where the effect of MMR vaccines cannot be seen. So let's say we look elsewhere in the world and rates of autism are increasing and the number of kids who are getting vaccines is also increasing. Well, that's alarming. There's a positive correlation there. If only we had a control group, a place where we could look for rates of autism in the absence of MMR vaccination. Here it is, the entire population of Yokohama. What we're looking for with controlled studies is the independent effect of the thing that we think is bringing about what we're trying to explain, whether it's a symptom, a disorder, etc. The rise of autism in Yokohama makes it pretty hard for us to argue that the rise in autism that we've observed in so many places is due to the MMR vaccine. One of the areas where attempting to get independent effects can be a tricky task is with expectancy effects. If I am in counseling or therapy with you, I likely expect for you to be helping me, and that expectation can, on its own, lead to some positive effects, i.e. a placebo effect. Now, there's nothing wrong with that. Improvement is improvement. The issue is that I would like to know that it is what I am doing in counseling that is yielding the benefits. But as you can imagine, in a world where people hold self-serving biases and pragmatic outlooks that say, well, if it works, I don't really care why, it's not too surprising that people don't always control for expectancy. I saw a rather egregious example of this in a textbook. It's a clinical psychiatry textbook that mentions two things in the same chapter. First, they mention that talk therapy for gambling disorder is highly effective. If you compare it to individuals on the wait list for talk therapy, then it's amazing. Great efficacy rates. But about 6 pages before that, the textbook had mentioned that placebo studies in which we give problem gamblers a little sugar pill and we tell them this will help reduce your gambling, 40% of the time this reduces their gambling by half or more, which is what's required to consider the treatment successful. So on one page they're saying simply expecting a sugar pill to reduce your gambling produces improvement 40% of the time, and on the other page they're saying talk therapy is better than a wait list. Well, forgive me if I'm not impressed, because apparently you could have given the people who are on the wait list a magic pill that would have greatly increased the rigor of your experiment, because 40% of your control/comparison group would then have improved due to expectancy. So talk therapy would have had to beat that in order to demonstrate its effectiveness. The compared to what question is very important when you're looking at psychological research and evidence-supported therapies, because so often the answer to the question is, well, compared to a wait list, compared to no treatment. And that's not necessarily impressive because that comparison doesn't rule out expectancy effects. What you want for rigor and to be able to say that your treatment method works, that I should do what you did, as opposed to just doing pretty much anything, is you should have your control group expect to recover. Put more generally, the control group should be as close to the experimental group as possible, including having whatever expectations that treatment group has. Just in case you've forgotten, placebo effect refers to improvement because improvement is expected. We see placebo effect most strongly, most frequently, most prevalently for reduction in pain, headaches, backaches, and knee pain. Improvements in mood, including self-reported energy, and placebo effects account for nearly 2/3 of the subjective benefits of many antidepressants. To optimize your placebo effect, you should take bigger rather than smaller pills, more colorful pills rather than white pills, capsules rather than tablets, because capsules look like they have magic inside, brand names rather than generic labels. You should pay more. More expense means more placebo. And the treatment should be more invasive. If you really want to maximize the placebo effect, go for surgery. So we see improvements in subjective feelings, and these are real effects, right? The mechanism by which they are working happens to be your expectations. So Pavlovian conditioning, association. But what gets improved are your subjective feelings like pain, your subjective sense of energy, your subjective quality of sleep, whether or not your stomach is in discomfort. These are real improvements through the mechanism of expectation. These improvements are not in your head. They are of your head in a sense, but they are real improvements. We can measure the physiological changes due to placebo effect, including blood vessel dilation, which could be responsible for things like improvement of headaches, changes to hormones, which are obviously linked with mood, changes in level of gastric acid secretion, which is why I put stomach discomfort up there, and the basis of the entire field of psychoneuroimmunology, the elicitation of conditioned immune responses. In other words, your body responding to something as though it's medicine because it has been conditioned to do so before. We also see, due to isolated effects of expectation, reduced brain activity in pain-related regions when subjects report improvement in subjective pain, and pursuant to the improvement in subjective pain again, increased measured serum concentrations of your own endogenous opioids. In other words, expecting something to reduce your pain helps you release in your own body endogenous opioids to fight said pain. Placebo effects are not all in your head, they are of your head, and quite real as effects. The flip side, of course, is the nocebo effect. Harm or discomfort because you expect harm or discomfort. We already mentioned here a link with stomach pain. Tiredness and dizziness and sleep disruption are also aspects more easily or frequently influenced by expectations of harm. This is usually when I ask the class if they have any placebo rituals, things that make them feel good that they know actually have no meaningful material effect, but they do because it makes them feel good. My general day-to-day example is every once in a while I'll take a vitamin. I know I don't need it, but sometimes it just feels good. Some students answer with more superstitions like knock wood or crossing their fingers. Your placebo rituals will likely be very idiosyncratic to you. I mentioned the meta-analysis results that antidepressants, or at least some of the antidepressants, share about 75% of their efficacy with placebo. In other words, whatever benefit you get from antidepressants, if you're the average or low average severity case, about 75% of that benefit would, on average, be obtained if you had just been given a placebo with the same expectations. Kirsch has multiple peer-reviewed publications on this, and I think 2 books. His first big report was getting his hands on the big data sets of submitted trials to the regulation agencies. So you have to show that your pill is more effective than placebo. And all of these submitted studies existed in a database, and Kirsch went into this database and said, okay, well, let's kind of average across all of these submitted studies of these, I think, 4 different types of antidepressants, and compare the efficacy rate for the placebos, because they were all placebo-controlled trials, compare the efficacy rates for all of the placebo groups bunched together, and all of the antidepressants or treatment groups bunched together. Quantified another way, the average improvement score over the course of treatment with the antidepressant was 1.8 units on the HAM-D, Hamilton Depression Inventory. But the minimum change in HAM-D score required to be considered improvement, the minimum for clinical significance, is 3 points. So on average, you don't have clinically significant improvement, though you do have statistically significant improvement. Statistically better than placebo. But I mentioned that this is with the typical or below typical case in terms of severity. If you have a more severe case of depression, then your improvement score will be much larger. If you are among the worst 11% of major depressive disorder cases, then your improvement due to antidepressants, or your expected improvement due to antidepressants, is well above the minimum for clinical significance. This is an example of a meta-analysis because Kirsch took hundreds of studies and combined them to get these results. We run controlled trials and meta-analyses because if we just follow what feels right, we're often wrong. In part because we have self-serving biases, and in part because we're wired up to see connections where things shouldn't necessarily be connected. This is called illusory correlation. There's also more generally the challenge of the emotional reasoning fallacy. Emotional reasoning isn't necessarily fallacious, but we tend to think that the more we feel something is true, the more true that thing is likely to be. And if you formalize this as a premise, then that constitutes a fallacy. You're not necessarily wrong, but it's not sound reasoning to say that the more it feels true, the more likely it is to be true. Sometimes an increased feeling of truth is a defense mechanism trying to protect us from the actual truth, which is that we're wrong. Put more digestibly, confidence is not correctness. and we're quite good at creating beliefs that are impervious to testing. This is a quote from a Reiki healing website. If the patient is skeptical, energy healing will not work, as the negative energy will interfere with the gentle healing energy. Okay, so if your treatment doesn't work, then it's my fault for not believing correctly in your treatment. How convenient for you. Here's a testimonial from someone who took the Reiki level 1 and then figured out how to heal himself from the sore throat that he had. So he drank tea, took vitamin C, and did Reiki. And 2 days later, he was cured of the common cold. And then he wrote down on this website, does Reiki work to bring about healing from the common and uncommon cold? You bet it does. Let's put this in our fourfold table from Intro Psych and look at where our confirmation bias would be if we believed in the power of Reiki. Was Reiki used? Yes or no? Did I get better from my cold? Yes or no? Well, fun fact, we get better from colds, usually in a couple of days. So you're probably not going to get any disconfirmations in the form of cell C here, where people try using Reiki but they don't get better from their cold. So you just need to get people to do Reiki when they have a cold, so that illusory correlation and confirmation bias can get them thinking that their recovery was due to their Reiki training. Why was that testimonial, this testimonial, up on the Reiki healing website? Who does that work on? Everybody, nearly everybody. It's called the law of small numbers. We're very easily convinced by case studies, anecdotes, and, as we see in the history of psychology, very small sampled experiments. It's our self-serving bias and the law of small numbers that we need to guard against by looking for independent effects and using controlled studies wherever we can. There are 5 pitfalls we can fall into, especially in abnormal psychology, that might make us think our treatment, our counseling, our interventions are effective when in fact they are not. First, spontaneous remission. Some people get better or change on their own, and they would have improved whether they had met us or not. If we have self-serving bias, we might remember those cases of people getting better as successes on our part. So we would have to go to the literature and randomized controlled trials in order to find a source of information that is not prone to being biased by spontaneous remission cases. Next, the placebo effect. Most people that we interact with in most therapeutic settings do expect something to be effective. There are, of course, exceptions, but on the whole you can expect placebo effects. These would get in the way of your learning whether it's specifically what you do that is effective or just the expectation that your clients have that you will be effective that is leading to effective results. Next is self-serving biases. This can be on the part of you, the clinician or counselor or helper, or on the part of the person you're helping. Maybe they spent a lot of time in therapy, did a lot of work, they did the homework that you assigned them, maybe they paid you a lot of money. This will motivate them to perhaps conclude or believe that treatment was effective when maybe it wasn't. And since you are also invested in thinking that improvement was reached or accomplished, it can be terribly seductive to just believe, trust, and not question your self-serving bias in any given case. Next, regression to the mean. Usually if people see you, let's say you're a social worker or a counselor or therapist, they typically see you when they are at their worst. And one thing that the bell curve tells us is if we are sampling from a person's experience and the value that we happen to get is an extreme value, but we're resampling again, maybe we're seeing the person in another week or a few days, what we can expect is the next sample will likely not be as extreme as the last sample. The good bet is not on the more extreme. Regression to the mean says if you have an extreme value, you would predict that the next value, the next sample you'll get, will be less extreme than that. If they're coming to see you when they're at their worst, the chances are the future times you will see them, they won't be quite as bad. And we tend to want to take credit for that, for regression to the mean, though it's of course not as satisfying as taking credit for spontaneous remission. Regression to the mean is one of the reasons why people argue for a stepped or gradual approach to diagnosis. So when you first see somebody, don't leap to a diagnosis after the first meeting. Wait and see whether after a few sessions they are still above threshold for diagnosis. If they haven't regressed to the mean after that time, then label and treat accordingly. Finally, much like self-serving bias, we have retrospective rewriting of the past. This isn't always self-serving though, so it gets its own box. At the end of treatment, somebody might say, well, I was probably a lot worse than before. I'm not 100% now, but I was probably worse before. Two things make the more scientifically minded psychologist amongst us weep. The one is the fact that most practicing psychologists don't use evidence-supported therapies. They just use whatever feels right to them. And this doesn't mean that they're not helping. It just means that they're not necessarily using their big fancy advanced degree. The other thing that makes scientifically minded psychologists weep is on the client side, or the consumer side, a lot of the efforts at education and awareness fail. And we like to call this, or I like to call this, science in, garbage out. An example, in the 90s, a woman claimed that she had injected her child, who had autism, with Secretin, and that this improved his verbalizing abilities. So she told the world about this, and other parents started using Secretin, and researchers said, whoa, well, we should look into this. So 15 independent, well-controlled studies showed that injecting an individual with Secretin does no more than injecting the individual with autism with salt water, which is precisely nothing. These scientists really wanted this to be a thing. They really wanted this to work. It just didn't. 0 out of 15 studies. Okay, so we should be able to bring this information back to parents, caretakers, decision makers, and have them understand and follow the advice that they should not be spending money for this Secretin drug. 69% of parents who were shown the results of these studies still reported that they wanted to, and that they did, spend thousands of dollars on Secretin treatments. Science in, garbage out. And it's a shame because we are constantly making lots of improvements in psychology and psychiatry. In the 1700s, Benjamin Rush greatly improved upon prior practice of treating the mentally insane. He took their chains off and he insisted that they be treated like family. What did he do to his family? He poured acid on them. He would cut their heads and then rip open the cut wounds so they would be open for months or years, because he thought that this facilitated the discharge of energy or pressure from the brain. He thought that scaring patients, like, for example, by putting snakes in things that they opened, was treatment. He would tie patients to chairs that were hung from the ceiling and then spin them for hours. He called that the gyrator. And you may have seen pictures of his tranquilizer chair, which is essentially a sensory deprivation seat that one is tied to so that one can't move an inch. And people would be frozen in place in this chair, potentially for days. And if you think he sounds like the worst of the worst, no, he was the best of the best in the 1700s. He's still on the seal of the American Psychiatric Association because he didn't keep the patients chained up, and he occasionally brought them fruitcakes. Yes, he was torturing them, but he was torturing them less and in different ways, and this was amazing. We have come a long way, especially very recently. It wasn't until the end of the 19th century that we stopped using bleeding as a primary treatment, and that we stopped emphasizing the balancing of humors. We will, in 100 years, no doubt, look back at a lot of what we do now as absurd and terrible. And that's why we keep looking for better options, and we embrace the logic of controlled tests. In conclusion, by all means, use case studies for understanding. Just beware of the law of small numbers. One case does not a rule make. Always ask, compared to what? Often you will be terribly disappointed by the answer, but will learn quite a bit from having asked the question. The fact that something feels right does not mean it is right, with respect to treatment, labeling, etc. And even if you have the best possible approach, method, theory, perspective, protocol, etc., keep looking, because even the best improves. In fact, that's what makes a thing the best. Improvement. Stay tuned.